Hello, hello all. We are today February 14 is as is celebrated in the West Valentine Day, but our message is a love also for all, but it's not by words, not by flowers only, but translated into action via scientific exploration and studies to lessen the burden and the suffering on millions of cancer patients in the world. It is a message for all, wherever they are and who they are, regardless of that. It is for all human beings. It is a message of love. So we start now with the first talk, and I would like to hear from all of you and from who will watch this video now. There are no much people till now, but or in the future, because it is will be announced in the web and the playlist to all videos, and we are waiting your feedback. Okay, we'll start now. Hello. Today is our 16th session of the GOIS, Global Oncology Implementing Science.
No, that's
Hello. Today is our 16th session of the GOIS, Global Oncology Implementing Science courses program of the GOU, Global Oncology University. This part is about series about the series about clinical radiation oncology. As we said before, we have broad aspect of clinical cancer care. In its heart is radiation oncology, surgical oncology, medical oncology, immunotherapy, and all types of modalities. Today, we present examples of scientific explorations of resource saving of better value in radiotherapy, breast cancer as a model. I am Ahmed Zawawi, chair of the Win-Win Initiative, Global Health Catalyst Initiative, Global Health Catalyst Win-Win Initiative, chair of board of directors of Global Oncology University, and founder and president of ICEDOC, Experts in Cancer Without Border, International Committee for Establishment and Development of Oncology Centers, past president of Aortic, African Organization for Research and Training in Cancer, professor of clinical oncology at Canada University, Malay, and chairman of Al Suleiman Radiation and Clinical Oncology Center, Port Said, Egypt. This is based, what we present today is based on chapter 16 in approaching global oncology win-win model, surely with updates and additional notes. Course directors of this series, Professor Carol Sikora, Professor Wilfred Negwa, Stephen Avery, Siful Haq, Tualib Ngoma, Taufik Ay, and Duka Nkorochi, Eduardo Gazab, David Kerr, Christina Stefan, Tualib Ngoma, Ricardo Odesio, and me. 3 common questions along this series to make clinical oncology radiotherapy more accessible and affordable in the world. We go directly we are focused on this. Is lowering total cost of cancer care possible without compromising the outcome? Yes, yes, yes. This is this is the win-win, and this is what we are doing together to try to explore and to present in a constructive way. In previous session, we gave tens of examples for systemic cancer therapy. The second common question is, could we double or more the number of treated patients with the existing available radiotherapy facility at present in the world? Yes, it is possible. If, we'll see what is if. Is that possible to increase remarkably the number of clinical oncology services in the world? Yes, it is possible. Yes, if among this if there is serious will, there is scientific approaches, flexibility of thoughts, and smart win-win models, new deals of that in all will win based on science, and that all stakeholders will win. The focus here is in this lecture is in examples that could lead to an increased affordability of good value radiotherapy. Okay, most of the present examples take breast cancer as a model that could be expanded to other cancers. In session 15, if you didn't attend, then it is a link. There is a link for all sessions. Tanzania U.S. Regional Advanced Cancer Care Cancer Center of Excellence Investment Forum, co-organized by the government of the United Republic of Tanzania and Global Health Catalyst. The same in the last session, 15th session also. Erasmus MEC Cancer Center, Rotterdam, Netherlands, and the opportunity for training and online education and other opportunity by Professor Luca Incroci. An introduction to an outline to the series of clinical radiation oncology by me. All this in the last session. If you need the PDFs of slides, if you need the link to video, please don't hesitate to contact. Next lecture, starting from next lecture, session 17. It will be 18, 19, 20, 21, 22. Could we increase access, lower total cost, and number of service of clinical oncology in the real world in the upcoming 10 years? Yes. 16, 17, and the next session will be the needs for research in radiotherapy fractionation, brainstorming notes about hypofractionation and the need of research in radiotherapy. Also, Professor Luca Incroci present Hypo Africa with Tualib Ngoma, Wilfred Negwa, and colleagues of ABA and all. Dr. Tawfiq Aj will present improving access to radiotherapy in low middle income countries through collaborative work initiative to reduce technology owned by Tawfiq Aj, Alexander Jenkins, Manjid Dozanj, Donna O'Brien, David Pisteman, and Professor Norman Coleman. Innovation, example, we give example, innovation of low-cost radiotherapy machine and novel ring-based compensator intensity modulated radiotherapy is very interesting, very exciting by Professor Eric Ford and colleagues. Innovation also, example of innovation in lowering the cost of image guidance in radiation therapy using low-dose megavoltage imaging, cone beam CT for accurate radiation therapy and delivery by Professor Ross Berbico. So it is a way to lower the cost and to increase access to the affordability of better value cancer care. What we say is by science, by innovations. Smart radiotherapy by material for combining radiotherapy and immunotherapy by Professor Wilfred Negwa and colleagues. It's very interesting. Molecular radiotherapy combining radioactivity with drugs that target specific tumor cells. Solar power radiotherapy by Ralph Muller and Holger Witz, Germany. And one of the upcoming lecture is what is about solar power, and this is presented by two pioneers in that field. Electronic brachytherapy. It's very interesting. Innovation still under study, like flash therapy, radiotherapy, a new ultra dose rate from 40 to 30 degree, 66 degree per second. Successful example of new services, Radiation Oncology Center in Kutaisi, Georgia Republic, by Professor Christina Kiel in Chicago, helping African Radiotherapy Center to overcome staff challenge experience in Mozambique. Is very interesting and very practical example here, applied in Mozambique by our colleagues in Mozambique, and Professor Francisco Alves and his group. Financing from Portugal. A financing solution for sustainable cancer control increase by the availability of novel radiotherapy, a proposal from Uruguay, South America, by Professor Alvaro Luango Cedipitis. This is based on chapters 42, which includes one of the upcoming, yes, it's included also in one of the upcoming session. Example of industries. Variant Semen Health Engineers, remarked to global oncology by Dr. D. Concha, including value-based radiotherapy in low-middle income countries, sustainable partnership for Africa variant medical system by Mr. Dow Wilson, past president and past CEO variant medical system, and Whitman, Kevin Masoudi, Julia Shelley, and Valerie Senden. Cancer does not discriminate between the rich and the poor. Precision radiation medicine for everyone and everywhere by Habib Naimi, Vice President of Electa. Here we present in session 16 today. I just give outline to all to know this is not to know where we are and where we go, and where we was and where we are and where we go in this direction. Together. Example of exploration of scientific avenues for resource sparing in radiotherapy for breast cancer. 1. Post-operative, post-mastectomy and post-lumpectomy radiotherapy for breast cancer. A. Altered fractionation schedule. We present here different schedule and different models to widen the scope. Altered fractionation schedule, shorter fractionation for post-operative radiotherapy, hypofractionation, accelerated and partial breast irradiation, concurrent booster radiotherapy during the course of the whole breast radiotherapy. B, less number of radiation fields. C, different option in techniques. 2 is palliative radiotherapy for bone metastasis. Shorter fractionation for post-operative radiotherapy, hypofractionation. The UK standardized breast radiotherapy randomized trial Start A for women with early breast cancer, T1 3A from T1 to 3A from T1 to 3A, N0 1 to 1 M0, a regime of 50 grays in 25 fraction. As you know, all of these the most common was fraction over 5 weeks was compared with 39 gray in 13 fraction over 5 weeks. 50 in 25 to compare to 39 in 13 fractions over 5 weeks. Start B is a regime of 50 gray in 25 over the 5 weeks compared with 40. Most of you are common with this with this regime also. 40 gray, 0.5 gray in 15 fractions over 3 weeks. The eligible criteria included an age over 18 and no immediate surgical reconstruction. The primary endpoint were local regional tumors relapse and late normal tissue effects. A 10-year follow-up confirmed that that this treatment is appropriate, though hypofractionation radiotherapy is safe and effective for patients with early breast cancer. The result supports the continued use for shorter fractionation for post-operative radiotherapy hypofractionation of 40.5 0.05 gray in 15 fractions, which has already adopted by most UK centers as the standard of care, for women requiring adjuvant radiotherapy for early invasive breast cancer. Here's some reference. Fast forward is a multi-center phase 3 randomized non-inferiority trial carried out of this number of patients, 97 hospitals, 47 radiotherapy centers and 50 referring hospitals in the UK. Patient aged at least 18 years with invasive carcinoma of the breast as the first trial T1 to 3 in N0 to 1 M0 after breast conservation surgery and or mastectomy were eligible. A randomly allocated patient to either 0.05 gray in 15 fraction over 3 weeks, 20 and 27 gray in 5 fraction over 1 week, 27 in 5 fraction, or 26 in 5 fraction over 1 week to the whole breast or chest wall. Allocation was not masked because of the nature of the intervention. 26 gray in 5 fraction over 1 week is non-inferior to the standard 40.05 in 15 fraction over 3 weeks. 26 in 5 fraction. And is safe in terms of normal tissue effects for up to 5 years for patient prescribed adjuvant local radiotherapy after primary surgery for early stage breast cancer. For now, moderate hyperfractionation with 40 to 42.5 over 15 to 16 fraction remains the standard of care for the majority of patients with breast cancer who undergo whole breast radiotherapy without regional node radiation after breast conserving surgery. In this study, however, have demonstrated equivalent tumor control and cosmetic outcome in specific patient population with shorter course of radiotherapy, approximately 4 weeks. Patient with their physician should review these options. There are many options, but should review, and some of them are approved by Astro and others. So it should be reviewed these options to determine the most appropriate course of therapy to their patients. The Astro choosing GOIS campaign recommending considering shorter treatment. This is the Astro American Society of Radiation Therapeutic Radiology Oncology. Recommend considering and choosing wisely, led by Professor Lewis Snipper, recommended considering shorter treatment when initiating whole breast radiotherapy as a part of breast conservation in women with early invasive breast cancer, with comparable tumor control, lower cost. Comparable tumor control, lower cost, reduced morbidity, hypofractionation should be strongly considered for the majority of patients with early stage disease. Look at this. With comparable tumor control, lower cost, reduced morbidity, hypofractionation should be strongly considered for the majority of patients with early stage disease. Astro recommended that the decision should be more appropriate, individualized. This is because still we should consider together that it is clinical. We are still you are a doctor, you are a radiation oncologist, you are a physicist, but this is a space to individualize your treatment for the better of patients and to study this scientifically. Individualized based on tumor factors. Based on what? On tumor factors, anatomic consideration, and patient preference. Those to the heart and contralateral breast, lung, and other normal tissue should be minimized. This is one of the important things. Okay, this is reference. There are reference here. As recommends that the decision be The dose given to the heart should be minimized. A tumor bed boost is recommended for patient ages 50 years or younger with any grade with any grade tumor, or in patient aged 51 to 70 years with high grade tumor or for positive margins. Other recommendations are also included, such as the treatment planning, the technique of the whole breast radiation, patient positioning, and other factors. There is a midway solution that could be reasonable, particularly for low and middle income countries. The fractionation of 40 gray as 45 gray as 20.50 gray per fraction in 18 fractions. It is 45 in 18 fraction. 45 in 18 fraction. Has been used in Porcide. We use it for many years for post-mastectomy treatment and in the whole breast radiotherapy after breast conservation surgery. It is not invented. Also, it follows the fractionation practice successfully for years since the 70s. Some think that this hypofractionation and this is a model and this is new fashion. No, there are many things that could be applied, but we search about it. It follows the fractionation practice successfully for years since the 70s in many French centers. Professor Salazar, Institut Gustave Roussy, and my professor Alain Logier, and Professor Michel Chilangier at the new hospital in Paris. I was young at that time and was practicing it as a young radiation oncologist and clinical oncologist and hematologist even. Hence, we reduce the duration and cost by 7 sessions of radiotherapy compared to the conventional radiotherapy of 50 gray in 25 fractions. With this technique alone, we can at least increase the opportunity of radiotherapy for around 30% more patients. So it is not theoretical things. It's not slogan to say increase the number of patients. No, with this technique alone, we can at least increase the opportunity for radiotherapy for around 30% more patients of breast cancer patients. Once again, without spending more funds, there's a lot that can be done. That's what we say always. There's a lot can be done to increase the affordability of better value radiotherapy for greater numbers of cancer patients. We advocate more studies for evidence-based hypofractionation, which should be conducted to other localizations, such as prostate, other indication, and one in different communities. And there are already many studies, as you see, in prostate and many others. Reference here, some reference. You can please revise this reference and see what is present there. Accelerated partial breast irradiation. The rationale for accelerated partial breast irradiation of small cancer without the adverse features predisposing to multicentric recurrence originated from observations that 80 to 90% of breast cancer recurrence after breast conservation surgery and whole breast irradiation occur in tumor bed. This is from 80 to 90%. I don't recommend this or not, but I expose for you all, and you see the result yourself and see the reference. We don't give liaison. We present examples and our personal opinion. We say at the end, but we would like to expose as much as possible many choices. The advantage of accelerated partial breast infiltration is that it would resolve dilemma regarding chemotherapy and radiotherapy sequencing and could perhaps be more cost effective. Several techniques, including multicatheter interstitial radionuclide brachytherapy, intracavitary brachytherapy, intraoperative radiation therapy, and 3D conformal external beam radiation therapy, have been proposed. All these used already. This is not new, and it's proposed and utilized since time. IMRT, and all, each of them has IMRT also. Each of them has its own pros and drawbacks. There are still questions about this technique and its equivalent with whole breast irradiation, despite its use in some centers in the United States and Europe. A total of 10 randomized controlled trials involving 500 patients, 15,500 patients with early stage breast cancer were selected according to inclusion and exclusion criteria and included in this meta-analysis. The analysis showed that the patients receiving this technique had a higher local recurrence rate, but no difference in distant metastasis. So everything will have its drawback and advantage. So we should read carefully, and we should choose what is better for our patients. But different in our community, and our localization, and our country, and our and patient preference, and many things, but no difference in distant metastasis. Breast cancer disease, contralateral breast cancer, disease-free survival, and overall survival rates with no problem in this. Because of the average breast size in some countries, such as Japan, is considerably smaller than in Western world, the application of this technique to Japanese patients is technically more challenging. So, as we said, this is not just read this technique, say this is successful, this result, this trial, but we should read the details. Our point of view is that in low middle income, this is our point of view, in low middle income countries, breast cancer cases are usually more advanced. However, this technique could be advised only for early breast cancer under certain circumstances. This is not routine at all, as shown by the example of electronic brachytherapy in a later section of chapter 16 and this series of lectures. This reference. And what do you think? Please, current boost radiotherapy during the course of the whole breast radiotherapy. One of the way to shorten the duration of radiotherapy without sacrificing the outcome is use boost radiotherapy that given concurrently during the course of whole breast radiotherapy itself, instead of giving it sequentially of whole breast radiotherapy. There are different ways. These are different ways to deliver concurrent boost radiotherapy. Don't dispute. There are many things. In a study by Jalali, a concomitant boost was given to the tumor bed on the non-treatment day of conventional course. For example, Saturdays, when the day is off in most Western country, 30 patients with locally advanced breast cancer suitable for breast conserving following the adjuvant doxorubicin, and now it is more modified, were recruited for this study, but this is the history of the study. Conventional radiotherapy to the whole breast was delivered 5 days a week from Monday to Friday to a dose of 50 gray using 6 to 10 megavolt photons. In addition, an election boost to the tumor bed was delivered every Saturday, 20.5 gray on 5 fraction, weekly fractionation on Saturdays. This is a way. This is one of the ways. It's interesting that there are other studies that deliver the entire course of whole breast radiation and concomitant boost in the same session in 3 weeks. The radiotherapy dose to the whole breast was 40 gray 0.5 gray at 2.67 per gray per fraction, with concomitant boost of 4.5 gray at 0.3 gray per fraction. So it is at this 0.3 gray on every session along the course of the course. No acute clinical toxicity criteria at grade 3 and 4 are no low late soft tissue toxicity were noted. The cosmetic results observed were good. To this studies demonstrate that giving a concomitant boost during the whole breast radiation is viable resource saving option that does not sacrifice the outcome and the cosmetic result. Cost is viable resource saving option. And these are the references. Less number of radiation field. Since systemic adjuvant therapy is given to most patients nowadays, the traditional radiotherapy technique has modified. It is no longer recommended to patients with who undergone completely or complete or level 1-2 axillary section for not heavy axillary lymph node involvement should receive full axillary radiotherapy. Since survival is not improved and the risk of lymphomania is increased. Also, the isolated internal memory chain failure is rare even when radiotherapy is not given. This is the reference. I present many points. So to study where we are and where your patient is and what is the benefit and to have flexibilities. In 2007, the IAEA initiated a prospective randomized clinical trial to compare the local control, regional control, overall and disease-free survival of stage 2A, 3A breast cancer patients randomly assigned to post-mastectomy radiotherapy with or without radiation of the supraclavicular lymph node. There were 469 women randomized. I contributed in this as PI as one of the PI in this trial of the IA with dear colleagues, and with our colleague Rosenblatt at the time it was in WHO in IA, a multi-center international. In the randomized trial, directly comparing supraclavicular radiation, 40.5 gray in 15 fraction, concurrent to the chest wall radiotherapy, versus no supraclavicular radiation and chest wall radiotherapy alone. Post-mastectomy and post-chemotherapy chest wall irradiated at 40 to 15 grays. Outcome and pattern of failure, survival, adverse events are comparable. However, but I would like, we expose everything. We are very, however, a meta-analysis of that randomized trial, EO-RTC trial, and this is a number, included 7,170 patients, concludes that irradiation of the lymph node regions improve outcome. And this is the I have the honor to be one of the colleagues there. My name is there. Out of that, I personally I am for. I take care and I look with great interest to the meta-analysis of this meta-analysis. It should be discussed. It should be according to the patient. Many. So when you have many options, as we said, for low middle income countries and for many centers, not in the big centers in the United States, but in many periphery, in many community and college centers in the United States, in Europe, in many, you should know more. Different option of techniques. In selected cases, prone position for radiated or post-lumpectomy radiotherapy is comparable to IMRT, intensely modulated radiotherapy, in saving lung and heart radiation dose of exposure, but with marked less time and effort and cost. If we combine with hypofractionation, then more remarkable resource sparing could be achieved. So if you combine hypofractionation with prone position for post-radiotherapy, then it's be marked remarkable resource sparing. But our comment, I see this point and this point, other point, our comment. This position could be done in some patients, not all. But it is not easy to perform by all patients in whom radiotherapy is indicated after lumpectomy. What do you think? We have sometimes that patient, we have this need some physical fitness, by the way. But it's one of the options. You see what could be fit your center and your patient. As we said, we are keen that in clinical oncology, and always as expect radiotherapy, medical oncology, and all. And we should know many options and valid options. We should know more in order to decide. So where is the way, or why is the decision if we have more option and scientifically reasonable? Palliative radiotherapy of painful bone metastasis, single versus multiple fractions, half body radiation, for instance, example, and the third is extensive test during follow-up of radiotherapy of bone metastasis. Palliative radiotherapy of painful bone metastasis, single versus multiple fractions radiotherapy remains the main modality of management of management of symptomatic bone metastasis. It's very effective. And it's the main modality. In such cases, the goal of radiotherapy, the goal of radiotherapy is to provide painful relief and optimize the quality of life with minimal displacement, discomfort, hospitalization, and morbidity for patients, and also to minimize the cost and time of concomitant. The performance status and the degree of systemic disease must be considered prior to treatment. So this evaluation, just not to say that is very effective, that is so we should apply it, but in painful. How and performance status and degree of systemic disease must be considered. It should be planned for tailored for every patient. The ASTRO choosing GOIS, the recommendation for palliative bone metastasis is that the study suggests equivalent pain relief can be obtained by the use of 30 gray in 10 fraction, 20 gray in 5 fraction, or in a single 8 gray fraction. However, a single treatment is more convenient, but may be associated with a slightly higher rate of treatment at the same site. So choose what is what fit your patients. Maybe it can come on you for one time, and you are not sure that you can come from far or something. Approximately 25 randomized clinical trial and 3 meta-analyses had demonstrated equivalent of single and multiple fraction radiotherapy for bone relief from uncomplicated bone metastasis. The other advantage of single fraction includes a decreased cost and lower risk of acute effects. The single fraction is preferred when cost utility is considered. A high rate of retreatment is associated with single fraction radiotherapy. However, most authors recommended multiple fractions for the primary treatment of complicated bone metastasis for which there is no surgical option or for post-operative treatment. The goal of post-operative radiotherapy here are the decreased pain, promote healing, and minimize the risk of progression. It is worth noting that treatment of symptomatic bone metastasis may be deferred unless the patient is at risk of serious adverse outcomes such as spinal cord compression or pending pathological fracture. Don't say this is not painful, but there is in the site it can be fracture. So we should not forget this is that we are decision maker. All of you, and the patient is between for our effort and our decision is should be we take care of all these aspects. Half body radiotherapy, single dose hemi-body irradiation is effective and safe for pain relief in 70 to 80% of patients with multiple site painful metastasis. Generally, the dose of lower half body is 80 gray in 1 fraction. For upper half body, it is 7 gray in 1 fraction, less, with reduction of the lung dose to 6 gray in 1 fraction by partial shielding. Studies also support the decrease the opioid use, a decrease in opioid use, and the need of localized and the need for localized external beam radiotherapy. Yes, it's cost effective. It is in decrease need of the use of opioid, quality of life, cost utility, many things. Patients should be pre-medicated and intravenous fluid with intravenous fluid, antiemetic, corticosteroid, and analgesic to avoid pain flare up. sequential treatment with both upper and lower limbs require a 6-week gap for the recovery of myelosuppression, around 6 weeks, around for the recovery of myelosuppression. Medial half body is not known much, but it is, but it is used by many experts. Medial half body 3D conformal radiotherapy has been used for widespread bone metastasis. Medial half body. The target includes the pelvis and bones and lumbar sacral vertebra and the upper third of the femur. Radiotherapy was delivered 3 gray fraction, 2 sessions, 60 hours apart on 2 consecutive days. Total dose 12 gray. So 12 gray on 2 days, consecutive days, using the 3-dimensional conformal radiotherapy or other techniques. Study have shown that half body radiotherapy delivering use the 3D conformal radiotherapy is safe and effective. There is a wide place for technology and everything. Reduction in the cost of some procedures used to follow up the radiotherapy of bone metastasis. The International Bone Metastasis Consensus Working Party recommended that the follow-up and evaluation of response should be clinical as far as possible. Therefore, biochemical and imaging studies are not routinely required in the follow-up of process. This represents a cost saving. The letter goes with the concept of choose wisely campaign and would be should adopt the methodology of the top list of oncology practice after okay this. And I would like to say that after personal discussion with Professor Lewis Schnipper, USA, he stated that it's not necessary to be the same the list of the United States, but to inspire the concept and methodology of the different countries. This is Professor Lewis Schnipper himself, one of the pioneers of this choosing wisely. Thank you for your attention. And we announce for the upcoming lectures. We have a very exciting lecture and lectures. As you said, as you presented in the list, the outline about clinical radiation oncology and radiobiomaterials and nanotechnology and many other things, solar powers and new techniques for cost saving in for IMRT and for image guiding and many other things, and of course industry. I would like to announce in this break that we have a series of panels with ASCO intervention, ASCO international webinars to have a big discussion with conclusions and outcome on the 5 sessions in 5 sessions that we presented before of systemic cost saving in systemic drug therapy. So please return back to this session and prepare your brainstorming question or raising question or inquiry, and we receive that from now till before 27 March. And these 5 panels, 27 March till 25th for April. The 5th panel will be about repurposing. There are many with the leaders from ASCO and the leader of most of the directors of this course are leaders in ASCO or Astro and whatever. Hello. Thank you for all of you for your attention. I would like to say that what we are presenting here will be the fashion, because there is no other way to concentrate in the upcoming years
on how to increase affordability and access to cancer care via scientific exploration. There is no other way, and there is no other way except if it could be consider the interests of all stakeholders. Otherwise, it will not be working in the real world because there are interest and incentives for many. So there is no other way. If we find no much people attending leave, but be be the advocate, raise the flag, and advocate for hundreds and hundreds. From our side, I promise, and we assure you that we'll do everything to promote and to spread the word everywhere. It will be the fashion. We are sure of this, despite that many things that is not going with some of the current things. But will be the fashion. This will be the approaches. So be leaders in that, all of you. Be advocate, raise the flag and add to it, modify and lead. Now the second part, and this reply a simple question which is very needed. We need thousands of people to listen to it. Decision makers, how to increase affordability of is it possible to increase affordability or decrease the number of cancer the patients who will receive the radiotherapies? Yes. Okay.
Well, this again, I come again. I'm very thankful to you to support my French international English. As I said before, French is my second language. English is my third, and my studies and even my postgraduate medicine and my early career was in Paris, France. So you have this sometimes this pronunciation is, but it is international English. You can consider it, and thank you for accepting that. If you can't accept, well, could we increase access, a lower total cost and number of services of clinical oncology in the real world in the upcoming 10 years? And this is the same course director. And three common questions, as we said, we remind ourselves always, because we should focus. This is our three common questions together. Is lowering the cost of cancer care. Sorry, here it is total cost. I'll repair it. The total cost of cancer care possible without compromising the outcome? Yes. In previous session, we have gave tens of examples of systemic cancer therapy. And a second question, could we double or more the number of treated patients with the existing available radiotherapy facility at present in the world? Yes, it is possible if, and we see together what is if. Is it possible to increase remarkably the number of clinical oncology care services? Yes, it is possible if, but we should work together, all stakeholders, for that. Smart, innovative deals, broad scientific exploration, and win-win models. It's not one model, many models. But should at the end should be for left for more innovation, more types of win-win model in which all will win. The winner will gain more, and the loser now will find the requirements of cancer care with dignity, the requirement with equity and with dignity. Well, general measures, General Strategic Planning for Radiotherapy Facility in Developing Countries. In 1999, a global strategy for radiotherapy was proposed in a consultation for the WHO organization. It considers the different local parameters, including the gross national product per capita, which categorize countries in the world into 4 groups or levels. Accordingly, a 3-tier series of radiotherapy was proposed with an internet-based intercommunication strategy. Here is the reference. You can see it. It is landmark, really, this reference. And we have the honor that 3 of the expert market in red here, Professor Kiro Sikora, who is the leader of that activity and who was at that time was the leader of cancer section in WTO, my friend Tualib Ngoma, and I was 3 on these 9 consultants. But at that time, Professor Porter was the head of the president of the American Radiation Oncology, American Radiation Oncology board or something like this. Of this, this consultation was led by Professor Kiro Sikora, head of cancer section, WHO at that time. Such a work would be cost-effective, help to bridge the gap, and give all patients access to state-of-the-art technology in radiotherapy. Also, there is reference for data, very interesting here. I cited Professor Data. It is a feasible, cost-effective solution. Data and AI suggested optimized teleradiotherapy networks through resource sharing could be a cost-effective and financially viable option to create radiotherapy infrastructure and facilitate capacity building toward utilizing the 2030 Agenda for Sustainable Development Goals in most low middle income countries. So it is not just saying Agenda 2030 and something, but should be to say how there is to say practically in science, in our professions. Low income countries and some low middle income countries that are not expected to show positive return on investment. ROI, it is ROI, it is ROI, it is return on investment, should be considered for external financial assistance. This only that. Practical modification of the system of work of the radiotherapy department if the existing system is not enough to cover the needs of patients with long waiting. Why not modify the system and to accept? Why accept long waiting? And if there is a way to cover the needs. There are several points and suggestions that deserve study in order they deserve study in order to increase the number of patients treated. For example, to increase the hour of work on shifts, particularly in developing countries. To increase the working days from 5 to 6 or 7 days per week. Everything is possible, but not accept a long waiting for time for patients who are suffering or coming from far. An increase in the number of fractions from 5 to 6 fractions per week. In a study, this is very scientific. This is based on scientific study. In a study accelerated 6 fractions per week versus conventional 5 fractions per week for radiotherapy in squamous cell carcinoma of the head and neck in a randomized international multi-center trial with 908 patients conducted by the International Atomic Energy Agency, IAEA. Accelerated fractionation study group. Local control was better in the group. In which group? Was better in the group selected for 6 fractions per week. In fact, this finding deserves more study for other tumor, particularly for the particularly the locally advanced lesions. And here is some reference. And this is a study done by Overgaard, the famous Overgaard et al. The reduction of machine downtime in many developing countries, which is mainly due to maintenance problems and the lack of culture of local regular preventive maintenance, according to Professor Vikram and many authors. In our view, we emphasize the importance of programs that should develop in order to ensure that most of the problem machine down can be fixed as soon as possible by local teams, either alone or using prompt telecommunication with the manufacturer's maintenance staff. We say developing and implementing widely, and not just talking about or planning for years, because we hear this from since years. Here's the difference. Professional education and training, we emphasize as the most mandatory element for resource-sparing, cost-effective treatment, better value treatment tailored for patient in different community, is well-trained and regularly updated medical, technical, and maintenance staff. This is a higher priority than sophisticated machine and techniques, because this is the backbone, human beings. Therefore, customized and regular updated training is recommended for the local medical, technical, and physicists and all, and maintenance staff. We consider this aspect in the education and training program in the Global Oncology University and this program of Global Oncology Implementing Science. We indicated that the curricula of clinical oncology and clinical oncology care and cancer biology, radiobiology, radiogenomic, pharmacogenomic, and all physics for low middle income countries should not be less than provided for high income countries. Should be not considered as primitive program and primitive education, but they should provide, as far as possible, different valid care options, hints, and pointers to scientific undertaking to solve a problem and for research to tailor treatment to get better outcome for their patients. This in addition to in-depth knowledge of the ready-made resources and guidelines for treatment produced by Western society and organization. Even so, they may not scientifically give the best result for their local patient in real life. This need scientific implementation and evaluation and study and good data and everything. Publications. Moreover, the curricula address the topic of how to establish and develop clinical oncology service, because it's not like advanced country. You go to service, everything is there, but sometimes you have to initiate the department, or it is present, but you would like to update and expand. So the curricula address topic like how to establish a department of clinical oncology, what clinical technical problem, what the layout, and many things. This issue deserves more global consideration for effective wide realization if we seriously want to see a breakthrough in the rate of increasing access to clinical oncology service in the world. What I'm saying, this is not exaggerated, but myself, I was subjected to this by my professor, my late Professor Alain Logier, and Professor Michel Chandier, particularly Professor Alain Logier, who gave us about how to build department, chemotherapy, development of something, and Professor Amiel from Gustave Roussy about chemotherapy and how to change protocol. And so. This is very important. It is not just a ready-made guidelines and just apply it. This is, but to know guidelines and to know heart and to know it and to know everything is essential. But it's guideline. It's not pathway to treat certain patient specifically. This is not for this Mr. or Mrs. X who is in front of you. This is in this group of patients. So what fit Mr. X or Mrs. X in front of you is that we should brain work. Conclusion: in a recent study conducted in USDA, around one quarter of 135 breast cancer patients undergoing mastectomy with strong indication for radiotherapy did receive their post-operative radiotherapy. Did not surprisingly, they did part of them didn't receive. Surprisingly, one of the reasons that they didn't receive radiotherapy was their socioeconomic conditions. Was not, I correct it. Hence, even in the United States, there are disparities in access to radiotherapy, but surely its magnitude and it is not comparable with the huge shortage in low middle income countries. There is a reference, you see it. Another surprising data that at least once in the course of the disease, more than one out of four cancer patients in Europe don't receive the radiotherapy they need. You imagine this. In this program, books and our presentation, we have just cited example of what can be done in scientific ways without spending any more or buying machines more, but spending to use what we have. And this is paves the way to expand and to appreciate and after and to expand it and advance big development and everything. By rough estimation, this action could double the number of patients treated and hence improve the affordability of radiotherapy, particularly in middle-income countries, without seeking more funds and without compromising the outcome. On the contrary, as shown here, some of the presented options would bring more comfort to patient and hospital visits. So you're not compromising the outcome. You can double the number. Just this would not lead to fewer purchases of radiotherapy equipment, but it would increase the opportunity to purchase after, because the gap is estimated to be at least 10,000 units in this decade. Contrary to belief, radiotherapy is cost effective and not that expensive. This is paves the way to more expansion. It is silent to note that the cost of one military jet would represent the entire cost of radiotherapy for a country in some part of the world. You imagine this. This is stated by Porter. This approach stated in this. Once again, there is a need for international forum in which all willing organizations, local bodies, stakeholder, and infrastructure comes to coordinate together within a win-win atmosphere to achieve the feasible objective of increasing availability and affordability of better value clinical oncology care for millions of underserved cancer patients. This is possible. We should go forward. Think together. There are many. All of you have their big role. Once again, we don't claim that anyone or single group could provide all solutions. No, not at all. What we present here are examples of what could be contribute with the contribution of many other examples and stakeholders to a remarkable increase in access to radiation oncology service in the world. We don't claim personal credit. We ask all colleagues and interested body to send feedbacks, suggestions, and ideas. Focus on how to increase affordability of better value cancer care with all modalities. To one of the available links here, if you need a PDF and text and everything, I am at your service. This is a continuous global forum and platform belonging to all, to which all are invited to contribute and to lead. Thank you all, and I am sorry. There are many things. There are many things to do. We just give some examples. There are other tens of examples. So let us navigate together in this journey. And you are the doers everywhere in the world. You are the leaders, particularly the mid-career generations and younger generations, not like me, an old who started his career in as a resident in clinical oncology in the 78. I was already a resident in clinical oncology in Paris. So please, your feedback, contribution, suggestion, either are recommended and are very, very, very appreciated and very warmly welcome. And going forward, as you say always, going forward hand in hand. Thank you all.
Thank you all. If you have any inquiry or question, but from my side, I would like to say that you are the leaders, and this uh, 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 endeavor will succeed by all of you. And this is not the only the future, but the very near future. By you all. Every one of you raise the flag and be the leader of such initiative. Thank you all. If there is any question, I see Will went. If any one or colleagues would like to add something. Okay, I think that we can close now. And as you saw, as you notice that the upcoming lectures is very exciting, and you can be the advocate for these advanced things that could lead to increased access and affordability of cancer cares for millions of human beings in the world. Millions of human beings in the world are screaming, be with us, screaming and saying to all of us, be with us as far as there are scientific solutions. Where is these solutions? There are, but we don't use. You advocate for this, and you are the leaders, not me. We are not claiming. We don't claim any personal credit. Thank you all, and thank you, Dr. Manar, for your nice word. And from Oppo, Oppo, who are you, Oppo? Because I don't know Oppo as 22. Oppo is Mahinor. Okay. Thank you, Mahinor. By the way, Dr. Mahinor, Atif, and Muhammad Abu Salama contributed in effectively in preparing the slides and the slides of the next lectures also. It is written in the PDF, their names and their affiliation. Thank you all, and till next time. Bye-bye all.